Vascular anomalies. Introduction. The greatest impediment to development of this field has been confusing terminology. This has been responsible for improper diagnosis, illogical treatment, and misdirected research. Vascular anomalies were often called hemangioma and specified by adjectives such as capillary, strawberry, cavernous, central, venous, etc. Unfortunately, the generic label hemangioma was applied to many types of vascular lesions, both congenital and acquired, with different etiologies and clinical presentations. Vascular tumors vs malformations. Vascular tumors are endothelial neoplasms characterized by increased cellular proliferation. Hemangioma is the most common and is almost exclusive to infants. Other tumors are hemangioendotheliomas, tufted angioma, hemangioparasitomas, and other rare vascular neoplasms, including angiosarcoma. Vascular malformations are the result of abnormal development of vascular elements during embryogenesis and fetal life. These may be single vessel forms, capillary, arterial, lymphatic, or venous, or a combination. Vascular malformations do not generally demonstrate increased endothelial turnover. Malformations with an arterial component are rheologically fast flow, while the remainder are slow flow. About 1/3 of IH is nascent at birth. 2/3 appear postnatally. Rapid growth in early infancy is the defining feature. In contrast, many vascular malformations are noted at birth, and they expand commensurately with the child. A biopsy is mandatory if there is equivocation about the clinical or radiologic diagnosis. Histologically, hemangiomas demonstrate endothelial hyperplasia and glucose transporter 1 protein (GLUT1) immunopositivity, whereas vascular malformations have slow endothelial turnover and are GLUT1 negative.
Diascopy can help to distinguish VMs from subcutaneous or deep hemangiomas because both appear bluish on clinical examination. Diascopy is performed by pressing a glass slide over the lesion and observing for blanching of the bluish deep purple color as blood is evacuated from the VM. In contrast, no color change is noted when diascopy is performed on a hemangioma.
Diascopy can help to distinguish VMs from subcutaneous or deep hemangiomas because both appear bluish on clinical examination. Diascopy is performed by pressing a glass slide over the lesion and observing for blanching of the bluish deep purple color as blood is evacuated from the VM. In contrast, no color change is noted when diascopy is performed on a hemangioma. The most common error in determining a clinical diagnosis continues to be the inaccurate and imprecise use of terminology. Cavernous hemangioma is an example, because in reality there is no such entity. A lesion is either a deep hemangioma or a venous malformation. Vascular tumors. The first and most crucial step in evaluating a patient with a maxillofacial vascular anomaly is to determine whether the vascular lesion is a tumor or a malformation. Newborn, infant and childhood photographs are reviewed with the parents to determine if the lesion was present at birth, as well as the rate of growth. History and physical examination provide an accurate diagnosis in more than 90% of patients with vascular lesions. MRI with gadolinium is the standard initial imaging technique for diagnosis of vascular anomalies. Vascular tumors. Hemangiomas are endothelial tumors with a unique biologic behavior. They grow rapidly, regress slowly, and never recur. The 3 stages in the life cycle of a hemangioma, each characterized by a unique assemblage of biologic markers and processes. Proliferating phase. During the proliferating phase, growth is rapid and frequent observation is needed to document the growth pattern. Few indicators predict the eventual volume of a particular hemangioma or forecast the timing and outcome outcome of involution. Typically, hemangiomas begin to plateau in growth by 10 to 12 months, although some demonstrate growth stabilization earlier or later. Involuting phase. During the involuting phase, after 1 year of age, the growth of the hemangioma slows. The skin begins to pale, typically beginning at the center of the lesion. The hemangioma is softer on palpation. The involuting phase extends from 1 year until 5 to 7 years of age. Involuted phase. 5 years of age. After regression is complete, all that remains are a few tiny capillary-like feeding vessels and draining veins, some of which can be abnormally large, surrounded by islands of fibrofatty tissue admixed with dense collagen and reticular fibers. Clinical features. Hemangioma is the most common tumor of infancy and childhood, occurring in 4% to 10% of Caucasian infants. These lesions are 3 to 5 times more common in females. There is an increased frequency of hemangiomas in premature infants, with a reported incidence of 23% in neonates who weigh less than 1,200 grams. Hemangiomas are unusual in dark-skinned infants. Hemangiomas are generally noted within the first 2 weeks of postnatal life. However, there is wide variability in this timing. Deep subcutaneous lesions, such as in the parotid, may not be noted by until the infant is several months old. Infantile hemangioma. A newborn infant with normal facial appearance, except for a small discoloration at the lower end of the philtral column. Infantile hemangioma at 4 months of age. The lesion shows rapid growth. Proliferative phase hemangioma and superficial ulceration. Infantile hemangioma. Frontal photograph at 6 years of age after 3 intralesional triamcinolone injections and excision at the involuting phase. Hemangiomas occur most commonly in the craniofacial region 60%, followed by the trunk 25%, and extremities 15%. 80% of cutaneous hemangiomas are single, while 20% are multiple. Multiple cutaneous lesions often are associated with hemangiomas in other organ systems, particularly the liver. Imaging features. On CT images, hemangiomas are seen as lobulated solid masses that are isodense with muscle and show intense enhancement. T1 weighted MRI, usually intermediate signal intensity. T2 weighted MRI, high signal intensity. T1 weighted post-GD MRI, diffuse intense enhancement. Hemangiomas need to be differentiated from arteriovenous malformations, which are also associated with prominent vascularity. There are 2 recognized subsets of hemangioma that demonstrate patterns of histologic and biologic behavior different from typical infantile hemangioma. They are both called congenital hemangiomas because they develop during prenatal life, present fully developed at birth, and do not exhibit the expected postnatal course and life cycle of the common IH-rich 1 type, known as rapidly involuting congenital hemangioma, involutes rapidly during the first few weeks or months of life. There is often superficial ulceration and, occasionally, signs of rapid arteriovenous shunting that can simulate an arteriovenous malformation. The distribution more commonly involves the trunk and extremities. Niche. A second, less common type of congenital hemangioma termed non-involuting congenital hemangioma persists into late childhood, and niche is usually not diagnosed until later in childhood because it was mistaken for common IH or presumed to be a small AVM. Clinical evaluation. Essential components of a first visit with the family of a hemangioma patient include 1. Confirmation of the diagnosis. 2. Photographic documentation. 3. Consideration of the need for pharmacologic or surgical intervention. 4. Determination of the need for other studies to establish the extent of the hemangioma or to rule out associated anomalies. 5. Referral to reputable sources of information and parental support. Clinical evaluation. Essential components of a first visit with the physical examination. Key questions to consider are: 1. Is there dermatomal involvement, jeopardy to vision, a beaded involvement, subglottic or stridor in the head and neck? 2. Is there ulceration? 3. Are there multiple cutaneous lesions? 4. Is there a lumbosacral or perineal involvement? Dermatomal head and neck involvement. If there is a dermatomal distribution in V1/V2/V3, consideration must be made of Faces syndrome. These hemangiomas tend to be macular vascular with superficial skin involvement and a seeming porosity of subcutaneous tissue. In these cases, it is important to look for associated sternal notching or a midline raphe. If this is suspected, a full radiologic workup is mandated, including head and neck MRI/MRA to visualize the carotids and circle of Willis, along with ophthalmologic evaluation. Pitfall hemangioma in the CNV distribution. Exclude faces CM in the upper face. Exclude Sturge-Weber faces IHs in the head and neck can arise in association with structural anomalies, which are not necessarily vascular in nature. This was not well appreciated until these various malformations were compiled as the acronym FACES: posterior fossa malformations, hemangiomas, arterial anomalies, coarctation of the aorta and cardiac defects, and abnormalities. The original acronymic designation FACE did not include the possibility of sternal nonunion or supraumbilical raphe. These were included later by adding S to make FACES. Visual interference. Periorbital hemangioma can block the visual axis, causing deprivation amblyopia, or extend into the retrobulbous space, leading to ocular proptosis. More often, a small hemangioma involving the upper eyelid or supraorbital area can distort a growing cornea, producing astigmatic amblyopia. The results of the ophthalmic evaluation will help guide therapy. Airway involvement. Stridosubglottic hemangioma is a common life-threatening lesion. The symptoms are typically hoarseness and, later, biphasic stridor. Evaluation of an infant with a cervicofacial hemangioma should include assessment of the airway. If pharmacologic therapy fails, a tracheostomy may be necessary. Ulceration. Ulceration can arise at any anatomic site. The infant becomes irritable from the pain, often feeding and sleeping poorly. Ulceration may destroy an infant's eyelid, lip, or nose. Ulcerated sites may become secondarily infected, leading to cellulitis, septicemia, and, in some cases, death. F. Multifocal hemangiomas. If large, can divert significant intravascular volume, resulting in high output cardiac failure, endangering and life-threatening complications such as high output cardiac failure with a large tumor or multiple intrahepatic tumors occur in 10% of hemangiomas. Overview of management. The standard of management is observation, reassurance of the parents, and excision of the fibrofatty tissue and abnormal skin after involution when the child is 8-12 years of age. It may be helpful in cases where there is family pressure for immediate operation to show the parents photographs of a similar tumor during proliferation and involution. For psychological reasons, a well-localized, disfiguring hemangioma can be excised, even if not fully involuted, before the child starts school. Overview of management. The standard of management. Indications for treatment: 1, 2, 3, 4, 5, 6. Well-localized tumor. Ulceration, bleeding, airway obstruction, subglottic lesion interfering with vision, upper eyelid hemangioma, distortion of the facial features. Treatment. Observation. Most hemangiomas are small, benign tumors, which should simply be allowed to undergo proliferation and involution. These will leave normal or slightly blemished skin. Usually, however, an infant with hemangioma is referred to a plastic surgeon because of the hemangioma's large size, rapid growth, dangerous location, ulceration, or potential for other complications. Pharmacologic therapy for complications. The precise frequency of endangering and life-threatening complications such as tissue destruction, distortion and obstruction caused by hemangiomas has been estimated to be 10%. The first line of medical treatment is corticosteroid, either topical, intralesional, or systemic, if the lesion does not respond to corticosteroid. Second-line pharmacologic agents include vincristine or interferon alpha-2b. Laser therapy. Pulsed dye laser is reserved for ulcerated hemangiomas or for treatment of persistent telangiectasias following involution. Operative management. Excision can be considered during each of the 3 stages of the hemangioma life cycle for select circumstances. Hygienic granuloma. Hygienic granuloma is an extremely common acquired vascular tumor in the pediatric population. These lesions can occur anywhere but usually arise in the face. Hygienic granulomas can grow rapidly, evolving from sessile papules into pedunculated tumors connected to the underlying dermis by a narrow stalk. They generally remain small, average diameter 6.5 mm. The treatment of hygienic granulomas is either curettage, shave excision and laser phototherapy, or full-thickness excision. Vascular malformations. Vascular malformations are localized abnormally formed lymphatic or blood vessels present at birth. Some vascular malformations are obvious, whereas others manifest later in life. They grow commensurately with the patient. It can be slow flow, capillary, lymphatic, or venous, or fast flow, arterial. If there are combinations, it is called an arteriovenous malformation, AVM, lymphatic venous malformation, LVM, or capillary lymphaticovenous malformation, CLVM. The first step in the care of a patient with a vascular malformation is to determine whether it is a slow or fast flow lesion. Complete resection is not possible in most cases, hence the possibility of uncontrollable bleeding during operation and the likelihood of recurrence. Capillary malformations. A capillary malformation, CM, occurs at birth as a macular pink stain that blanches with pressure. It is also known by the 19th century term port wine stain. The cutaneous discoloration is often, but not always, evident at birth. The stain may be disguised by the erythema of neonatal skin. Facial CMs often occur in a dermatomal distribution in the lower and mid-face. There can be maxillary or mandibular overgrowth with labial hypertrophy and gingival hyperplasia in all patients with an epiphyseal CM. A diagnosis of Sturge-Weber syndrome should be considered on initial presentation. Patients with a CM of the alveolar ridge frequently develop gingival overgrowth, and hygienic granulomas are common to prevent these lesions. Patients should practice good oral hygiene and receive regular dental cleaning. Operative procedures in the oral cavity, such as gingivectomy, extractions, and osteotomies, can be done without concern for excessive bleeding in the presence of a CM. Sturge-Weber syndrome. Sturge-Weber syndrome consists of a facial CM with ipsilateral ocular and leptomeningeal vascular anomalies. The capillary stain can be ophthalmic, V-E-F-L-L-A Vlavniro, 2V, Irolixum E-H-T-Otni Nidnex, 1 Simotimodulan image. Leptomeningeal anomalies can be CM, VM, or AVM. Small foci can be silent, but extensive PL vascular lesions can cause refractory seizures, contralateral hemiplegia, and variably delayed motor and cognitive development. Treatment. A pulsed dye laser is standard treatment. Photocoagulation might prevent fibrovascular overgrowth. Cobblstoning. Significant lightening of the CM occurs in approximately 80% of patients. Multiple sessions are generally required and often need to be repeated several years later. If there is cutaneous overgrowth despite laser treatment, staged excision and skin grafting should be considered. The most common operation for a facial CM is contour resection for labial hypertrophy. Orthognathic correction may be indicated for occlusal canting caused by asymmetrical maxillary overgrowth or mandibular prognathism. Lymphatic malformations. Radiologically and histologically, they are characterized as microcystic, macrocystic, or combined. In the 19th century, microcystic LMs were called lymphangiomas and macrocystic LM were called cystic hygromas. However, these terms are outdated and should be avoided. Macrocystic occur below the mylohyoid muscle in the neck, most frequently in front of the sternocleidomastoid muscle. Microcystic commonly involves the tongue, the floor of the mouth, the cheek, the lips and the mandible. Clinical features. The overlying skin is usually normal, but may have a bluish hue. Dermal involvement can manifest as puckering or tiny pathognomonic vesicles, which resemble minute blisters that become a dark red color as a result of intravesicular bleeding. Facial LMs are localized or diffuse, and may associated with skeletal overgrowth. LMs in the tongue and oral floor cause macroglossal with dark stained vesicles on the dorsal surface. Cervicofacial LMs are associated with overgrowth of the mandibular body and resulting open bite and anterior crossbite infection. Two major complications are infection and intralesional bleeding. LMs enlarge commensurate with the child's growth but can suddenly expand as a result of cellulitis, often occurring along with an upper respiratory infection. The inflamed tissue is typically tense, warm, and erythematous and can lead to airway obstruction if there is involvement of the floor of the mouth and tongue. Intralesional bleeding. LMs can also expand as a result of an intralesional hemorrhage from small vessels within the malformation and present as oozing from mucosal and cutaneous vesicles, commonly in the morning upon awakening, possibly due to the increased venous pressure of sleeping supine. This has been documented in 8% to 12.6% of lesions. When this occurs, there is sudden swelling and ecchymosis. Intralesional bleeding is a predisposing factor for infection, and antibiotics should be initiated. Management overview. Sclerotherapy. Detonetta 432 KO. Management overview. Sclerotherapy. Detonetta 432 KO. Lonate-2 Streptococcus pyogenes 1 ronisimol % sodium tetradecyl sulfate for macrocystic LM. Small well localized LM can be excised excisionless recto macrocystic senchtuanoit amraflam sitapmil ilacipit sartavika ebtunyam nois exitelt mognat corpanoits eseditorak tuakipsligner apra pht otni pednetxxen ehtniesml datslaw mleht note nerida severanty na irritra. Patients with large microcystic cervicofacial LM require serial, staged excisions of the floor of the mouth and submandibular tissues or phonathic surgery after soft tissue excision to minimize recurrence and manage malocclusion and distortion of the maxillofacial skeleton. Venous malformations. VMs are the most common type of vascular malformation. These lesions have erroneously been referred to as cavernous hemangiomas. They are developmental abnormalities of veins composed of thin-walled, dilated channels of variable size and mural thickness with normal endothelial lining and efficient smooth muscle. VMs generally occur in skin, subcutis, and submucosa but can involve muscle, viscera, and the central nervous system. Venous lesions are blue-purple in color, soft compressible, and non-pulsatile. Venous anomalies usually grow in proportion to the child, but enlargement can occur with trauma or may coincide with puberty and pregnancy. VMs characteristically expand with a Valsalva maneuver when the patient bends over with the head in a dependent position or with jugular vein compression. Phlegm thrombosis is common within venous anomalies because of stasis and recurrent localized pain, distension, and tenderness. Of frequent presenting complaints, phleboliths can be palpated or seen on plain radiographs and on all MRI sequences. Patients with an extensive VM or LVM generally involve the overlying soft tissue and commonly cause skeletal alteration and hypertrophy without intraosseous involvement. Oral VMs can cause malocclusion as a result of the mass effect on the dentoalveolus. There are, however, rare instances of VMs within the facial bones. The most common intraosseous craniofacial location is the mandible, followed by the maxilla. They are rarely found in the frontal, zygomatic, and nasal bones. Unfortunately, these lesions have been called central or intraosseous hemangiomas in the literature. Imaging calcified phleboliths. Gradual contrast medium enhancement from periphery to center. Telxum ot esnet neopiro osi. I'm death due 1t. Langus haging. I'm death due 2 light bulb sign. Comma phleboliths may cause round but not linear flow voids. Teoteripyrep morphnemic name nisekni ilornag. I'm d gene subdeath due 1 dark redneck. Computed tomographic scan with contrast demonstrates the large malformation extending into the soft tissues.
Axial T2 weighted MRI shows high signal area with signal voids of phleboliths arrows.
Axial T2 weighted MRI shows high signal area with signal voids of phleboliths arrows. Indications for therapy. 1. Appearance. 2. Pain-free. Functional problems. The primary therapeutic modalities are sclerotherapy, surgical resection, or a combined approach. Sclerotherapy, the mainstay of treatment, and involves injection of an agent into the anomalous channels, resulting in endovascular destruction, clotting, and obliteration. Small varicosities of mucosa and skin can easily be treated in the office with a local injection of 1% sodium tetrahydroxide tetradecyl sulfate. Resection should be carried out after completion of sclerotherapy when there are no remaining large venous channels. Bleeding is controlled with compression. Bleeding after teeth extractions is controlled by packing with pledgets consisting of microfibrillar collagen avitine, Davil, Warwick, RI, wrapped in oxidized cellulose sheets, Surgicel, Ethicon, Sumville, NJ. Dartleys are held in place with 2/0 chromic catgut figure of 8 sutures across the sockets. Extractions should be performed after sclerotherapy. Fast flow vascular malformations. Arteriovenous malformation, AVM. An AVM is composed of abnormal communications between arteries and veins without the normal intervening capillary bed. Expansion of an AVM is the result of increased blood flow through the lesion, not cellular proliferation, and subsequent tortuosity of adjacent feeding arteries and dilation of veins. Fast flow vascular malformations. Arteriovenous malformation, AVM. An AVM is composed of abnormal communications between arteries and veins without the normal intervening capillary bed. Expansion of an AVM is the result of increased blood flow through the lesion, not cellular proliferation, and subsequent tortuosity of adjacent feeding arteries and dilation of veins. Collateralization and recruitment. AVMs are present at birth, but they may not be clinically evident or are misdiagnosed as a CM or hemangioma. They rarely expand in infancy or early childhood. More typically, they grow proportionately starting in late childhood. Usually, years go by before they pose a threat to the patient. Nevertheless, rapid expansion can occur following local trauma, attempted excision or ligation, or hormonal changes associated with puberty or pregnancy. AVMs of the head and neck are less common than slow flow anomalies. Primary skeletal involvement occurs in the tooth-bearing bones, which are invariably expanded by the malformation. AVMs of the jaws may be asymptomatic or present as a pool. Satile swelling, localized throbbing pain, toothache or earache, or unexpected hemorrhage following dental extraction or exfoliation. A loose tooth in a bleeding socket should be treated with extreme caution. Bleeding can be fatal. The most effective measure is immediate packing and pressure. Preoperative embolization before extraction of teeth is useful to help control bleeding. An extensive AVM can cause increased cardiac output and, ultimately, congestive heart failure. The typical radiographic findings are an ill-defined radiolucency or a well-defined multilocular lesion. Clinical diagnosis is confirmed by US and color Doppler examination, MRI and/or MRA to find the extent of soft tissue involvement. Angiography shows variable degrees of arterial dilatation and tortuosity, arteriovenous shunting, and dilated draining veins. Angiography is rarely performed unless intervention is planned under the same anesthetic. Overview of treatment. Superselective arterial embolization is performed by an interventional radiologist. The principle is to obliterate the nidus of the malformation with embolization materials. Thus, inflow to the AVMs is reduced with low risk of collateral flow development. Superselective embolization may be performed electively and followed by resection, or it may be required as a life-saving procedure in the presence of acute bleeding. Proximal vessel embolization is contraindicated because of the rapid development of collateral flow to the nidus of the AVM post. Embolization angiography is obtained to ensure reduced blood flow in the malformation, and the AVM is examined for clinical improvement. Skin color, size, pulsation. Resection. Partial or complete surgical resection of soft tissues or bone is performed 1 to 3 days after embolization. Embolization does not decrease the extent of resection. Hypervascularity makes hemostasis difficult intraoperatively. Even after embolization, intraoperative embolization must be available. All small arteries that supply the AVM should be ligated except the main proximal arteries. Teeth extraction after AVM embolization in patients with intraosseous malformation in the tooth-bearing portions of the maxilla and mandible. Teeth may be removed 24 to 48 hours after embolization insertion. The sockets are packed with avitine and surgical pledgets and oversine. Once the sockets heal and the wounds are completely mucosalized, the malformations often become quiescent and remain in Schalbinger stage I. This is probably because the irritant of mobile teeth constantly being compressed by occlusal forces and perhaps chronic low-grade inflammation are eliminated. Indications: intervention is indicated for complications such as 1. Repeated hemorrhage, 2. Persistent pain, 3. Ischemic ulceration, 4. Cardiac failure.